Good afternoon, everybody, and welcome to this January meeting of the Derby Health and Wellbeing Board. I'll get straight into it because we're a little late starting, but thank you for coming along, everybody who's here. Do we have any apologies?
Yes, we have apologies from Councillor Wright, Councillor Lonsdale, Louise Curd, Sam Dennis, Gino Di Stefano, Lee Sharrod is covering, Dean Howes, James Joyce, Stephen Posey, Emma Aldred, Lucy Allen, Mark Powell and Jane Needham. And that's all.
Thank you very much. There are no late items. Do we have any declarations of interest? Oh, thank you. Just turning to the minutes then of the last meeting on the 14th of November. Is the room happy to accept them as an accurate record of the meeting? And are there any... Councillor Hesselgrave? Thank you. Yeah, we usually just take the room assent here rather than nominations. Thank you. And are there any issues that anybody would like to raise from the minutes, matters of correction or matters arising? I did go through and look at all the recommendations and there was nothing specific to raise today following from the recommendations of that. Thank you very much. So we will then quickly move on then to our first item, which is the Derby and Derbyshire Safeguarding Children Partnership Annual Report 2023-2024. And before I pass over to Sue-Ann to present that report, I've decided just to remind the room, before we hear the reports, what the recommendations are. And the recommendations here, in summary, are to note the report, to note the three priorities emerging from the report, and interestingly, so this is something we might want to have in mind whilst we're listening to the report, is to report back to the DDSCP in March 2025 on the actions taken by the Health and Wellbeing Board in support of the above priorities, and to establish effective coordination of what is known about the vulnerabilities and risk to children that inform both the work of the DDSCP and the Health and Wellbeing Board. So that's an ask there, and that's a report back from us. So just to make you aware of that before Sue-Ann presents a report. So thank you. Over to you, Sue-Ann.
Thank you, Chair. And I did have a presentation of a few slides, but I think we're having some technical issues, so apologies for that. So I shall carry on. Okay, so I'm of the understanding that the annual reports used to come to the Health and Wellbeing Board historically, and for whatever reason they stopped. So I suppose this is more of refreshing and re-establishing that connectivity between the Children's Safeguarding Partnership and this board on that formal basis. In terms of the Safeguarding Partnership as it is now, it is a joint partnership between Derby City, Derbyshire and the police and health, and it's been in place in those joint arrangements since 2019. So today we are looking at the report, and you have that. It's quite a lengthy report. I'm not intending to go through all of that. I'm hoping that you will have all read that. So that's the 23-24. And I want to just set out, I think will be really helpful for the Health and Wellbeing Board, just a little bit of context around the Safeguarding Partnership for you. Sorry, then there would have been a slide that would have identified all the key partners there. So reading from my slide, it is a statutory entity as of 2019, and the primary statutory partners have to be the local authority, the ICB and the police. but we have 4 because we have Derbyshire as well. It makes it a very large partnership, and we are quite unusual nationally to have such a large partnership, and majority of those areas that have had a single footprint have gone back to a smaller partnership over the period of time since 2019. However, we find that our current arrangements have been very effective. They've been run incredibly well, and we whilst a large partnership, it is functioning really, really effectively. We also work alongside a lot of schools. So when I say 569 schools, that's all the schools in Derby and Derbyshire. And we work with a lot of providers of services to families and children in the early years, childcare, health providers, acute and community, probation, voluntary and independent sectors. The main functions of the partnership are essentially around assurance that effective safeguarding services are delivered. So that's overseeing the quality of practice and local outcomes for children and families, identifying key challenges and emerging priorities for the local area, coordinating the joint agency strategic plan, reviewing the application of referral and thresholds across agencies, coordinating the views of children, families about services they receive, and critically to use any learning from local practice and serious incidents to improve multi-agency practice. And finally, we have to publish an annual plan on the effectiveness of the safeguarding arrangements in the local area. My next slide was going to be a little bit of a structure chart showing all the subgroups and everything, but we'll make sure that this goes out with the paper so that you can see that. And again, like most areas of work, we are always subject to constant change, and the safeguarding arrangements are no different. In 2023, working together, dictated or mandated really that we needed to revise and review our structures and put in place a much more robust governance arrangement, which we are beginning to do, and we're part way through those arrangements. So we used to have an independent chair, and now one of the statutory partners rotates and chairs that meeting, and so on and so forth. So we have refreshed our threshold guidance. We have refreshed our multi-agency dispute resolution and escalation. We've refreshed and got a protocol for assessment and support, and we're in the process of implementing our local child protection practice standards. And again, there's training available on this through the Safeguarding Partnership, and I will share the link if any members would like to attend that. So in terms of priorities moving forward, 2024 to 27, the partnership have identified 3 specific priorities. So that's domestic abuse, online harms and neglect. And the next step, after the Chief Officer Group have ratified those 3 areas, is to draw together the evidence, an extended understanding of that problem, and what are we going to do about the impact on safeguarding. And I think this is potentially where the discussion around, where perhaps the links come in with the Health and Wellbeing Board around shared data to underpin some of that. And if you'll see in the report, there is mention around how structurally the Safeguarding Partnership should link with the Health and Wellbeing Board in terms of sharing information on the Joint Strategic Needs Assessment, for example. So that would be one particular area that we could work collaboratively across. So the three priorities for the next 3 years are those of domestic abuse, online harms and neglect, and I'd like us to think about how in this board that we could be supporting those across the piece.
Joanne, I
Yes.
can only apologise. I've got slightly blocked ears.
Oh, right,
Sorry
okay.
for oversharing to the room, but could I ask you to speak up slightly, please? Because I just didn't hear that last bit. Thank you.
Okay. So I've got the microphone on as well.
No,
Are other people?
I'm not that
Is anybody
deaf,
else
it's my
struggling to
ears are
hear
a
me?
bit blocked. I'm sure everybody else in the room can hear you
Okay.
fine.
So in terms of the last part, Chair, I was kind of referring to your opening lines around what could we do to work together, and one suggestion was around potential areas from the Health and Wellbeing Board is the responsibility around the Joint Strategic Needs Assessment. The Safeguarding Partnership have identified 3 priority areas: domestic abuse, neglect and online harms, and that could be an area where both boards could be supportive of each other. So I think that's what you missed. Okay. So I think in terms of the report, unless there's any questions particularly from the annual report, I think you've set out what the recommendations are in the covering report. The idea was to have start a discussion around how we could strengthen that relationship, and that could be through a number of different ways. So I think I shall leave it there. Thank you, Chair.
Thank you, Sue-Ann. That's really helpful. Apologies that you couldn't share your slides, but thank you for preparing them. I did myself read the report. Does anybody else have any questions or comments? Councillor Hazelgrave.
Thank you, Chair. I note on page 8 of the papers we have on the forward plan, there's a reference to discussion items, one of them being Gambling Harm Action Plan Update, which doesn't feature on this agenda, but hopefully will occur soon. And I would like to have something considered at that, which are the findings, and it's a kind of youth voice or young person's voice, the school nursing TLM update, in which all the young people at year 6 and year 6 and 9, reception year 6 and year 9 were surveyed about various aspects of their health and well-being, and it emerged for our year 9 pupils that 15% of the children that were surveyed, and it wasn't 100% of the school population in Derby, I think it was high 70s, so we still have some late returns. 15% were saying that they were gambling, and that was probably online through something called Roblox, I think, which is a gaming site. And 2% of them reported that they're having trouble or think it's actually out of their control. On that basis, we haven't surveyed year 12 on that, or school nursing programme haven't, but they will be doing in the next round, probably next year. Seeing that there's a trend there, I do think that could form part of discussion when that gambling harm action plan update takes place, particularly since online harms are part of the recommendations at 2.1. And clearly, it might be that was being considered in terms of adults, but clearly there's a problem at younger than adult. If there's a curve there, we want to get ahead of that curve and try and take some action in relation with schools, clearly, all schools in the city. Yeah.
Yeah, thank you, Councillor Hazelgrave. That's a really good suggestion. I know the gambling report was Robin Lewis's annual report from the Director of Public Health. So do you want to respond to that, Robin?
Yes, absolutely. Very happy to look. Perhaps we could be in touch after the meeting and just have a look at what to bring. But yeah, very, very happy. We are due to bring an update, absolutely right. So we can include some consideration in that. Thank you.
Okay, thank you for that. Amjad.
Thank you, Swan, for the report. It's just a quick question in relation to buy-in and involvement from faith communities, in particular faith communities that are minority in the city. Do we have that? Is there involvement on the board from faith communities?
There isn't involvement on the board itself. Looking at the chief officer group, it's a very, that's a statutory partner, but there are opportunities in these subgroups and further down the structure where there is absolutely that collaboration and consultation. Certainly there's a lot of interface with the voluntary sector.
So I read the report, Sue-Ann, and I noticed there was a comment on the police and their engagement with domestic abuse and some actions they've taken in the last year. I think this was this report, because there's quite a lot of reports in here. It is this one, isn't it, where it talks about, and obviously the actions they've taken to deal with that. And in fact, from the Adult Safeguarding Board earlier in some point last year, I had a meeting with, I can't remember the woman's name now, from the police, who is sort of leading on this, and talked about how they're responding to domestic abuse or violence against women and girls. It was more violence against women and girls than domestic abuse. And it did seem impressive, although it's a little bit concerning that initially they were being challenged on the way they were dealing with elements of domestic abuse. And I suppose, I think we don't have anybody from the police in the room, do we? No. It is my intention within the next few weeks or so to meet with Lindsay and to go through the members of our board and to remind people who haven't attended for a while of their membership, and to ask them whether they want to remain members or send someone else in their place. But I think, is there, I'm sorry, I don't know if this is a sensible question, Sue-Ann, so bear with it, but I mean, in terms of domestic abuse, I mean, obviously it's something that is deeply concerning and I know has a profound effect on children. What kind of, I'm not sure that we've discussed domestic abuse at all, and since I've been the chair in this board, I'm just wondering what kind of actions or approaches that we could take that would be helpful in that respect. Robin, I don't know if you've got any thoughts, or Sue-Ann. As I've asked Robin, shall I let Robin come in, and then please do come in, Chris. Thank you.
Well, I don't have any specific thoughts, but I was going to propose that we just have a small group together to have a think about it, and also as to whether there's some. I know that my colleague in the county has been very involved in the domestic abuse work across the city and the county as well. So just to seek some other thoughts about how we might be able to bring that forward.
Right, so we can see it as a kind of work in progress then. Yes, thank you. So did you want to come in, Sue-Ann, or shall I bring Chris in first?
My view would be around that wider support to females, males, from a trauma-informed perspective. I think there's something around recognising potentially this area, I don't know, within perhaps the health and wellbeing strategy, and also, I suppose, in terms of any commissioned services that this board directly is accountable for, to look at how does that potentially could support or help or take into account domestic abuse. And I will just say, in terms of for the city, 50% of my referrals that come in regarding children are domestic abuse related. It is incredibly high, and the police are also dealing with an incredibly high amount of calls for action service in relation to domestic abuse. It is probably one of our key areas of challenge and pressure in the system. Thank you, Chair.
Thank you, Sue-Ann. That's helpful. I mean, one thing I think we could do is then ask our police members to report to us on domestic abuse, bring a report on specifically that, and perhaps some of the border issues, obviously, as well. Chris?
Yeah, thank you, Chair. Sorry, just a microphone issue there for a moment. It disconnected. This is clearly a really important matter. From the various meetings I attend with different partners, I know that the partnership is collectively addressing it. So the absence from the Health and Wellbeing Board shouldn't be taken as an absence of activity in this space. So that's what I'd say. However, we just need to be really careful, because one of our challenges as a partnership is the multiple different forums that we have. We're no different to any other area, but we have a huge number. So the forum where this would principally be being looked at would be the Community Safety Partnership as one of the key areas that is, again, multi-agency. So I think there's a question about mapping the question about where is it, seeking some assurance that we are dealing with it, but not possibly then bringing it here, because we are addressing it in another forum. So we may want to report from that forum on it, as opposed to bringing other colleagues back here. So I just wonder if that's the action we take. We just seek some assurance that we definitively are looking at it from a partnership and where, and then have a report from it. And then when we do our, I think as Sue-Ann was saying, when we do our Health and Wellbeing Board strategy, it's about understanding the connectivity of it as opposed to possibly having it here. Anyway, I hope that's helpful. Thank you.
I take your point, Chris, but my point is more the point is this, is that the Health and Wellbeing Board is a partnership. It's not something, we're not a delivery board. So, you know, people bring things here and then I can't like commission, well, obviously I can talk to Robin, encourage Robin to take actions, but you know, we don't then deliver. So it's about the partnership's only as strong, isn't it? It's the same at the ICP as people who turn up and participate. So if you only come when it's an area that's specific to you, you're not getting the broader picture. I mean, I agree with you in relation to the CSP, but then that's a question of thinking through, you know, is the membership alongside looking at the health and wellbeing strategy, and I think we will add this to the health and wellbeing strategy as you suggest, Sue-Ann. It's actually saying, well, if people never come and they're not reporting, and we don't even think areas of their activity are relevant for our board, then why are they members of this board? And I think that's what I'm thinking through right now. So I'm not saying people aren't relevant to this board, but if they're not here and they're not participating, and we think their work isn't relevant to report here, then, you know, we need, that's a question I want to ask as the chair, because I want people who are members to feel that they should come and do come. And obviously they can't come all the time, and I don't like duplication, but it's just about having a clear view of what we're doing and who should be a member. And if we feel they should be a member and they can never come, then they need to send somebody in their place. I think that's the point. Thank you.
So I think, yes, I agree with you. So if we've got a health and wellbeing board with an established membership and members are unable to attend for whatever reason, that needs review. Yes. What the point I'm making is specifically around domestic abuse, and there's another partnership that's probably looking at it on our behalf, and we need assurance of that. So I agree with you on the point of...
Yeah, no, I understood that point. Thanks. Yes, thank you. Andy, thank you.
So I just wanted to say that in terms of adult safeguarding, we have over 50% of our referrals come through relate to physical abuse. It's not domestic abuse in the same way, but one of Sue-Ann's requests was about sharing information and data, and that will obviously be a part of that. Suzanne and I will have those conversations outside of the board, but just to make it clear to the attendees.
Thank you, Andy. Yeah, that's... Sorry, can you remind us of your name? I know you say this every time, and you're from the fire service, I know, aren't you? You're a fireman, and can you tell us your name, please?
Yeah, Clive Stanbrook from Derbyshire Fire and Rescue Service. Just to pick up on a couple of points that Chris has made, really, is that the community safety boards is undergoing a bit of a reinvigoration at the moment, which I'm sure everyone knows. And I know part of the Police and Crime Commissioners, well, one of her 6 objectives, one of I think the second in the list is domestic violence. That's then going to feed into the statute. We're one of 5 statutory partners with the police. Obviously, work very closely with. I know it's been taken incredibly serious at the revamped community safety boards. Now, I agree with Chris, where the conduit comes into here, I'm not sure, again, whether it should be the fire service that brings in the domestic violence aspect or whether it's the police invitation. I'm not sure, but yeah, I do agree. There needs to be some sort of conduit from the revamped community safety boards, and the next meeting of that is the 6th of February, so there may be a little bit more clarity after that into the Health and Wellbeing Board, so I do agree.
Thank you. And Sue-Ann.
Thank you, Chair. I suppose just going back to what role and function this board could have, and I think it's, as alluded to, both in the report and as I said, around how the JSNA can inform, because that's primarily for this board, isn't it? Is it not the JSNA? Is it linked? Yes. So that, therefore, that data set would no doubt inform Community Safety Partnership, the Children's Safeguarding Partnership, etc. So I suppose I just want to place that on the table as a potentially tangible area for consideration of how this board can support the interdependencies on the other boards. Thank you.
Thank you, Sue-Ann. Any other comments on this? I just have a comment which is more content related, really. Thank you, not sort of more bureaucratic and procedural. It's just that, I mean, we do constantly have statistics on, full stop, but here we've got some statistics about the numbers of children living in deprived households in Derby and then obviously in Derbyshire. And in, so that's on page 6, 3.2, and on page 7, 3.7. And it's quite shocking, really, the numbers. I mean, we know, in a sense, but it's still it always, I think it retains its shockingness every time you look at this. But what's really noticeable in both sets of figures presented here is that actually there's a kind of sort of roughly 50% increase in the number of children living in deprived households from one year to the next. Now, I think that what's caused that, I mean, I know we have rising numbers of children living in deprivation, but do we have any reflection on that? I mean, is that, or do we know what, I mean, that 50% statistical increase is very significant. So is it how the figures are being collected? Is it, frankly, the two-child benefit cap coming in, because that's suddenly started to have, not suddenly, but that's starting to bite in the last few years because of the delay, because it wasn't retrospective, was it? I mean, what is accounting for that figure as presented in this report? Does anybody have any view on that, Sue-Ann?
I mean, I think, Chair, it's really complex, but I think it's arising from growing inequalities, and compounding over time of cost of living, impact of the pandemic, and I think is there an item on the agenda around child poverty? So I think we can perhaps look at that in a bit more detail. But this is absolutely right. The UK is depreciating in terms of its standards of living for all citizens. Year on year. I think we were 6th a few years ago, we're now down to 29th. We are, and our children are suffering probably the most in that. But I think it's well rehearsed and well known.
I think I'm aware of that, Sue-Ann, but I still think a 50% increase in 1 year is surprising. Unless we're not exactly starting from a very low base, are we? It's not like the 50% is numerically small, but thank you. Paul?
Wrong one. Yeah, I think, I say this regularly, I think part of the problem is the lack of awareness of the city as a whole of the increase that's steadily been building around child poverty. And I think, you know, we discuss stats and all this time at lots of environments, but whenever I'm with business leaders or members of the public that have no dealings with children particularly, the city is not aware of increases that we're seeing. And I think part of the thing that we have to do is communicate to the city some of the issues we are facing, because actually child poverty, as I always says, yes, there's statutory responsibilities, but there's a collective responsibility as a city, and we are not collectively as a city taking responsibility, and that's for a lot of reasons. And the danger is it always gets thrown onto the city council or health or whatever, it's your problem, but actually as a city as a whole we need to make people more aware, because the stats across child poverty are shocking whatever you look at as a city. And I've got my own little phrase that I use, that I think many people at times are aware of child poverty, but they're not awake to how drastic it is. And I think collectively we have to own it as a city, and we don't, if we're honest. We don't. And so I think it's been an underlying building issue that has all those things that, you know, Sue Ann has mentioned. But I think that the issue we don't talk about, because we all have to be careful, is probably the lack of awareness we've had as a city of how it's been growing over the last 10 years. And we've not really addressed it for a significant period of time. Collectively, I'm not saying the City Council or anyone is saying, but collectively we have not addressed it. And so it's got to that point that is drastically bad. You know?
Thank you, Paul. I don't disagree with anything you've said. I just think that normally if there's a 50% jump in 1 year, as is claimed here, there'd be some kind of factor within that is about a benefit change, or it's about the way the statistics are collected. I'm not saying, I mean, I'm not for a moment qualitatively challenging what you're saying at all, but I just think that's a bit curious. So I don't know if we could perhaps at some time, whether you could dig deep into where those stats have come from for us, please, Sue Ann. But Chris.
Yeah, I mean, this is bread and butter work for the Health and Wellbeing Board, in my view. So when we next do the JSNA, have a conversation about that, the priorities, strategies, when we do start well, this is front and centre, isn't it, of the conditions. In relation to the report in front of us, it's an important aspect from which the CSP works in terms of the circumstances and the risks. So from the report, it's there because of the sort of context in which the CSP operates and those we look after. But taking it out of that, it's definitively Health and Wellbeing Board territory, isn't it, in terms of the risks we're trying to manage as a partnership. Thank you, Chair.
Yeah, thank you. Well, I think we might want to dig a bit deeper into that. I'm not saying the figures are wrong, and I'm not saying anything you said, Paul, is wrong. I think that is a statistical. I'm not a statistician, but I do think that is statistically significant. You've got to think that it's gone up from 21.8. I mean, that is roughly 50, to 32.5% of children. So obviously that's practically a third. In 1 year. So if that's happening now, if the same factors are persistent, we're going to have, you know, over 40% of kids in the city. So there's something going on there that I would like us to do. I mean, I think it's just important. It's not that important in a sense, because what's important is that we know there are large numbers of kids in poverty, and we're not recognising it enough, not doing anything about it. I'm not trying to be pedantic here, or maybe I am, but it's more about actually. Is there something in that we ought to recognise? Because is it really escalating at that speed right now? I mean, and it could well be. I'm not saying it isn't, Paul. Sharon.
Sharon Buckby, I'm the Director of Learning, Inclusion and Skills for Derby City Council. I completely concur with you, Chair. I think there's the issue about child poverty and its increase in Derby is fundamental to every single part of the works that we do, whether that's those becoming known to early help in children's social care, whether there are particular challenges within schools, whether in terms of ongoing economic inactivity or the reliance upon different forms of benefit rather than exploring or not having the opportunities to explore wealth increase, to move out of poverty, housing. It cuts across every single aspect of of the work that we do as a system. So, you know, I would welcome a focus on this because it drives our demands in so many different ways, and we're not yet able to support in the best way possible. So this goes back to your point about the city taking this, holding this responsibility in different ways, Paul, I think, as well. So I would welcome that conversation. Councillor Martin.
Thank you. Yes, so we do have, we do need to move on, I'm aware. I just want to just dwell on that for a minute, though. And obviously, we are focusing on children in this section of the meeting. And obviously, we specifically asked Paul to come back for these reasons to talk about child poverty from the Child Poverty Summit that one of us went to. So we will come back to this. I mean, the reason I think we need just some analysis of this is because you've got the same, pretty much the same percentage increase going on in Derbyshire as well, which suggests to me there's some benefit change or there's something which is really pushing this up. But I think perhaps we do have a lot of knowledge in the room about child poverty in the city. We have perhaps the best knowledge in the room about child poverty in the city. But I think this is something I did a while ago ask the Child Poverty Action Group to come and address this meeting, and I've got everybody must come in now. So we are going to continue to work on this, but I think we should just definitely get to the bottom of some of those figures, come back to it, Sharon, again, perhaps again and again, and see what action we can actually take or try and drive in the city about this. So just before we move on then to two other aspects of this really, in the next two reports, Councillor Hazelgrave and then Heather.
Thank you, Chair. Just on this matter of being aware but also really importantly awake to this whole issue of child poverty in the city, we must remember that these figures that we have and that increase that we have are recent historical data. We don't have anything for 23 to 24 or anything for 24 to 25 in those figures. We have to assume on that there is an upward trend that is going to be revealed when those figures come out. And the second thing is that one group of people and professionals in the city who are awake to this are our schools. And they're clearly dealing with this day in, day out, as best they can. They make ad hoc arrangements with all sorts of organisations. I'll include the YMCA, that I know one school is involved with, and certainly Food for Thought for lots. But the voluntary organisation, the voluntary sector in the city is helping immensely with this and responds to any request for need. So I just wanted to have that on the table, that our schools are aware and awake. It's a macroeconomic issue, of course, which all we can do is alleviate poverty and do our best to get people to become more resilient. But it depends on a whole different mindset in terms of what the economic growth and prosperity of the city, the country and city going forward, how that translates down to those families that are living in poverty.
Thank you, Councillor Hazelgrave. Yeah, I agree. I mean, just say I believe the figures in question, because it isn't specified in the actual report, must relate to 23 and 24, those higher figures, because that's when the report, that's what implied, because that's when the report is pertains to 23 to 24, doesn't it? So they're fairly recent, but I agree, we need to look at it more carefully, and it could be increasing further. Heather.
Thanks, Chair. Heather Greenan, Director of Corporate Management here at the City Council. I suppose I just wanted to reiterate that the City is taking this seriously. We are working in partnership to tackle poverty. So hence, the work of the Poverty Commission, the Poverty Action Group, and obviously all the work to develop the poverty strategy, which, we have updated Health and Wellbeing Board on. So I guess I just wanted to reflect that work, and Paul will pick up at item 7 anyway. So thank you.
No, absolutely, Heather. I'm sure nobody thought for a moment, as I said, particularly in this room, we have the experts on child poverty in Derby in the room. It's just, we do need some more. I think we could ask the author of this report to give us some explanation of those particular statistics, I think. And we will come back to it. And we did look at it last time, and we're looking at it now. So it's a constant theme, but thank you. So I think, so thank you very much for your report, Sir Anne. It's really helpful, really important work, and I'm pleased that you brought it to the Health and Wellbeing Board. So now...
Sorry, Chair, can I just ask in terms of the other recommendation around the feedback from this board, what collectively am I feeding back? Thank you.
Well, you were asking for feedback by in a year's... Was it in a year's time? Was it? Have I got the... I don't know. Does it actually go? I'm in the wrong year. I haven't moved into 2025
in March
yet,
this year.
mentally. Sorry?
So the request is for this board to feed back in March this year.
As soon as that, yes, apology. So. When I did read March 2025, but mentally I was thinking of next year. Right, Robin, have you got any thoughts on that?
So I think the key issue, Swan, was around the JSNA, wasn't it, around those areas. So can I suggest that we have a meeting after this, and we'll need Alison Wynne in that meeting as well, just to look at and those areas a little bit challenging and about where that data might be, but we can have a conversation and just see what's possible from that as well. Thank you.
It's very helpful. Thank you, Robin.
And perhaps we could have just a little bit of feedback on that, Robin, at the next Health and Wellbeing Board coming. I don't think we're used to anybody presenting such urgent deadlines in this board, Stuart. And I think I do know what year it is, sort of. Thank you. So now we've got another concerning report, I would say, about infant mortality from Robin Jewish and Public Health Officer Sean Gill.
Don't we need to accept the recommendation?
Well, we don't formally. I mean, we can. Well, we have. I presume that the room has accepted the recommendation. I mean, normally we just assume that they have, but I can formally ask the room if they accept the recommendations of the report. Yeah, thank you. Okay, thank you. So, Robin or Sean, who's presenting? Sean.
That'll be me, thank you, Chair. And are the slides working, Lindsay? Great, perfect, thank you. So we're just bringing this piece today because sadly, as I'm sure everyone in this room knows, not all children who are born will live to see their first birthday. And it's this which the term infant mortality directly relates to. It's the first 28 days of life in particular that are the most vulnerable for young children, and the causes of death for young children tend to be related to factors such as prematurity, low birth weight, congenital conditions, and sudden unexplained death in infancy, this latter being where, despite looking at the cause of death afterwards, no specific reason can be attributed to that death. And then it's given the name sudden unexplained death in infancy. And some of these overall deaths are sadly unavoidable, but some of them are preventable and there are things we can do. So we wanted to bring this item today to raise awareness of the issue, provide the Health and Wellbeing Board with an overview of what the underlying reasons for infant mortality are, and then to also update on what we're doing to develop a system-wide response to help tackle this. Next slide, please. So we've got a graph here just showing rates of infant mortality per 1,000 live births, and great steps have been taken across England, the UK and internationally to bring infant mortality rates down, and they have come down over the last several decades, and you can see in that grey line a steady decline. That has stalled over the last 10 years across the country. But before that, we were seeing those improvements primarily thanks to improvements in medicine and public health. The rates for Derby are in the green line. Now, because of the small absolute numbers that we have in Derby, infant mortality relates to about roughly 17 deaths in Derby a year. Because of those relatively small absolute numbers, any variation from that, up or down, does mean that the rate can change quite dramatically from one year to another. Hence, the line jumps around quite a lot. But consistently, we do have higher rates than the England average. And this is in part because of challenges associated with being in a city, such as higher levels of deprivation and poverty, as we've been discussing. We'll discuss more later. Next slide, please. And when we put that into context with the region, apologies that the text is a bit small for people, but the different local authority areas are along the bottom, and we see Derby is the third red bar along. So we do have quite high rates compared to other regions, but the three highest local authorities are the city local authorities. When we then look at the county authorities, those are then similar. So we're middle of the pack, as it were, of the city local authorities with our neighbours. Next slide, please. But as has been discussed at this board several times, and as I'm sure everyone's aware, this isn't equal across our population, and we see that people in deprived areas have nearly twice as high infant mortality rates as those in the least deprived areas. And we also see variation based on ethnicity. So those of black ethnicity in particular have the highest rates nationally of infant mortality, about twice as high as those of white ethnicity. Next slide, please. So again, not all deaths are avoidable, but a number are preventable. And to understand the reasons of why we have these avoidable deaths taking place, the Derby and Derbyshire Child Death Overview Panel, or CDOP, undertook a review of neonatal deaths to see what those common causes are. And CDOP is a statutory group that meets to review every child death to see if learning can be taken to help prevent future deaths. So they pooled all of this to undertake this review. This report was published in 2023, and on the back of that, the public health teams at Derby City and Derbyshire County Councils undertook a deep dive to explore these common factors in further detail. And at the same time as this has all been going on, NHS England have been undertaking a programme of work to ensure high healthcare performance of services. So our work here is to complement, not duplicate that work, and our deep dive therefore focuses on the wider determinants of health, so those factors that relate to our behaviours, environments and networks that influence health. Next slide, please. So our deep dive has shown a number of different things contribute to infant mortality. It's a complex picture. We can group it broadly into child risk factors, such as being born early, low birth weight, how you're put to sleep, so people might remember the Back to Sleep campaign. We have maternal risk factors, such as being overweight, substance misuse or smoking during pregnancy, environmental risk factors, but there are also protective factors, so use of folic acid and vitamins, routine vaccination, and also establishing social circumstances so we can provide support around mothers and families. Most of these are well understood and can be influenced in one way or another. So despite the challenge, there's that positive element that there is something that we can do about this if we work on these levers. Next slide, please. We start to see just how complex it all is when we look at just one of these risk factors. So I've pulled out prematurity as an example here, and you start to see just how interconnected or reliant they all are in one way or another. So we can see that maternal overweight and obesity is a risk factor for prematurity, but on the previous slide we saw that it's also directly a risk factor for infant mortality in and of itself. If we extend this diagram further to the left, then we see that prematurity doesn't only lead to infant mortality, but it also feeds back to some of those other risk factors we saw. So prematurity is a risk factor for things like low birth weight. Also, again, complicating this web, prematurity doesn't only lead to infant mortality. Some children born early will live, but some of those who do survive who are born early will go on to have chronic health conditions. So if we're able to work at the core root causes of this, we really can have large and wide-ranging impacts on people's health. Next slide, please. And so we then started to try and distill what those common risk factors for those major reasons are. This diagram might still change slightly as we're finalising the piece of work, but I thought it was helpful to just bring a flavour to the board. And so on the left-hand side, we've got those factors which increase the infant mortality rate and therefore we need to mitigate. And then on the right, we've got factors which decrease the infant mortality rate and we therefore need to promote. Again, this isn't everything that contributes to infant mortality, but these were the most common ones that sort of cross multiple causes of death. Next slide, please. To do this successfully, though, we need a whole system approach. It's beyond any one organisation being able to bring about this change. If we look at the factor of healthy diet, for example, we know that it's not as simple as just telling someone that they need to eat a certain way. We know that it's not down purely to individual responsibility. There are lots of other factors that influence what we eat. So it's the availability and affordability of healthy food. If the person is surrounded by social pressures in certain environments, then it's harder. So you need to try and improve the diet of partner, friends, families as well. You need to tackle widespread beliefs. A lot of people believe, I'm pregnant, I'm eating for 2, I need to double my calorific intake, which isn't the case. And you need to work through different touch points. So women who are pregnant see their GP, their midwives, the family hubs. And of course, it's important to say that lots of good work around this is already happening across the city. What our work seeks to do is to try and bring some of that together with a focus so that we can more systematically see where gaps are and join up our efforts. Next slide, please. And so we've brought together and convened a group where we've got in the membership colleagues from the City Council, including ourselves in Public Health, Children's Social Care and Early Help, the Derby Place Partnership, ICB, clinicians, midwifery services, health visiting, and Community Action Derby as well. So we had our first meeting in December. We've got another meeting next month where we will continue to develop a plan based on the learning we've done so far to identify what we can do moving forwards. I think a key part of that is recognising the importance of preconception health, because not only does that improve the health of women more generally, but with about half of pregnancies being unplanned, being able to improve the health of women before they get pregnant is really key to make sure that those births are then healthy and successful moving forward. So then last slide, please. So our recommendations to the board were to consider how this important topic can be included in the reviewed Health and Wellbeing Board strategy. And also we'd just like to ask members, partners of the board, to consider how they can influence those common risk factors that we've identified, and also to consider how they can incorporate into their messaging ways to reduce infant mortality. So thank you very much, Chair.
Thank you. That's very succinct, Sean. Excellent report. Thank you. And some really important work, and you raise a really, really important issue. So before we look at the recommendations, which we'll just leave up there, that's so nice that you put them up there, because that's, in a sense, what we need to focus on, isn't it, in these reports in the end? Are we actually going to follow on? And so we'll leave those there, and I'll just take comments. So first of all, I've got Councillor Ashby.
Firstly, firstly, put the microphone on. Thank you very much for the report. I have to confess, I was horrified that the infant mortality rate is so high in Derby, and that we're so consistently above the national average. My background was health. I worked in general practice for many, many years, and I was really conscious of the umpteen times, countless times, when I would confirm somebody was pregnant and they were not taking folic acid. I could not believe in this day and age that there was such a lack of knowledge amongst people of all abilities of the importance of taking folic acid before you get pregnant. And as you rightly said, 50% are unplanned. And when we look at the people who are part of the new group you've put together to look at it, I'm thinking, why isn't education there? You know, if we could educate the teenagers, because we know in Derby we also have a problem with teenage pregnancies, and certainly in the areas I worked in, there were certain communities who wanted teenage pregnancies. You know, there were certain cultures who really want to, you know, leave school and have a family. And I just think, could we not get more involvement with education on all of the factors that impact infant mortality? You know, diet, folic acid, deprivation, you know, smoking, drinking, all of those things. But, you know, that if the teenagers could recognise those and actually take them on board, maybe we might have some impact down the line.
Sorry, it feels weird turning my back to you, but it's for the microphone.
Yeah, can you just talk to the mic, please, Sean?
So,
we're cast, and so people, she'll be able to hear. Carmel is familiar with this. She's used to councillors talking at length and having her back to her. So if you do need to talk to the mic.
Yes, absolutely. Thank you for that. Really great comment, and one of the things I did actually put in the paper and I forgot to put on this slide was just if anyone has suggestions of other people who could be involved in the working group to please mention it. So thank you for that suggestion, and we'll definitely take that on board. Separate to this piece of work, but it can very much link in, we're looking in the public health team at what our children and young people offer is with schools at the moment. So that would definitely be a way of helping to feed some of this messaging in as well. So thank you.
Thank you. Councillor Havelgrave and then Cathy Clay.
So thanks very much, Dr. Sean, for this report on a really sad issue, as you say, and I think we want to make sure that all our infants get the best start in life. I noticed on one slide you talked about maternal cessation postnatal. Yeah, obviously prenatal would be brilliant, but postnatal, surely both parents' cessation is important. It says maternal, but paternal or other partner cessation is equally important because they obviously have an influence on the quality of the air in the household.
Absolutely, and that's a great point. I think that risk created by maternal smoking is higher in the same way as primary smoking itself. It's more damaging than secondary inhalation, but absolutely you want to try and reduce smoking within the household and close contacts. Thank you.
Thank you. So I've got Cathy is next. Thank you.
Thank you, Cathy McLean, I'm Chair of the Integrated Care Board. Thank you for the report. I thought it was a really good, succinct, but very impactful report, so thank you for that. And one of the things that struck me is that you've set out really clearly, unlike some things where there's a lot of things that can be influenced. So it's not it's very worrying to see the figures, and I accept the issues around small numbers, etc. But if you look at that in the context of all cities, really, we have got a big challenge. And I suspect that if we'd had the conversation a year ago, we'd be looking at something not dissimilar. We could have a very similar, and if we look at it in a year's time, unless we do something, we'll have another similar conversation. So I suppose what I'm saying is, it's great to see there's a group coming together. I'm not sure if you've got primary care on there or whatever, I think you probably have, but there's probably lots and lots of people to come together. But it feels to me as though, is this something that we want to put our collective will behind? Because it feels dreadful, really, and also influenceable. Some things are not. We can't alter some things. But I note that it also quite nicely aligns with the integrated care strategy in terms of the start well element of that. So there are a few things aligning. So I'm not trying to provide an answer, but it just feels as though we could all, in all our different areas, really, really be challenged, either through that group or other, to say, what are we actually going to do? Because there's such a link here with poverty, but also a number of other influenceable things. Why are people not taking up the things? And we understand quite a lot about you need to work very closely with communities. They're not just going to do it because you tell people, but working with communities. But it's hard yards, I would say. Thank you. Not really a question, but it's just more of a...
Thank you, Cathy. Sure, I've got quite a lot of people waiting to ask questions, so unless you've got a very specific response to Cathy, if that's right, I'll bring in the others and then... but thank you, Cathy, and I think that's really helpful comments there. So I've got Amjad next.
Thank you, Sean. And for us, from a voluntary sector perspective, it's good to see the whole system approach being applied and the coming together of the organisations. But because for the last, I would say, couple of years since Core 20+5 came in, maternity was identified and the key ones with high inequalities. So the sector for us, we often get pulled to whether it's from Family Hubs or the LMNS work that's happening. So it's good to see that coming together. We're just about to launch, when I say just about to, probably around March time, a piece of insight and engagement to explore the whys. So Kathy, your bit in terms of looking at that within the heart of communities, because we know, looking at it, that deprived communities, in particular ethnic groups in them deprived communities, do have a lack of trust with the system and system partners. So the voluntary sector plays a significant role in this. Our support is there, and we've just had confirmation whilst I sat in this meeting that the ICB will be contributing towards this insight engagement piece as well, that, they're match funding it with the Family Hubs piece, Start to Life, that's happening. So City is in a good place, and we've got to tackle this together.
Thank you, Amjad. Thank you for that. Councillor Kerr.
Thank you. I was also shocked to see the levels, and in 4.7, at the top of that page, it says something which you would expect me to leap out and notice, that children from Black and Asian ethnic groups have been shown across England to have mortality rates nearly twice that as high from white ethnic groups. And that immediately says back to me vitamin D. And there is also the links, and a quick Google will show that there is research done on this, and yes, there is a link in vitamin D, which isn't mentioned elsewhere in the report, and I think it should be. And in terms of maternal deaths as well, there is a strong link with vitamin D as well. And I just think we really do need to put this on our agenda. It needs to be something that we actually look at. I was talking to somebody last week, who is involved in doing medical research as a master's in medical research, not in Derby. And they were saying that vitamin D is something that people think they know a lot about, but nobody is actually researching it and applying it. And I think those statements, things like ethnicity, come again and again, and it's again in deprivation. If you are on a low income, you don't buy your vitamin D, you don't give it to your children, it all costs money, and it's more important to give them food or get new shoes or whatever it might be that they need. And I just think we must stop ignoring it.
Thank you, Councillor Kerr. So, because we're a public, I'm going to let Sean come back in a moment, because I've got two other people who want to make comments. But as you've making a kind of sort of health intervention recommendation there, Lucy, I'm just going to ask Robin Jewis, as the Director of Public Health, to respond to that particular suggestion. Thank you.
Thank you. There's a really important aspect of that, isn't there, around Healthy Start and the vitamins that should be available and should be taken, both by pregnant women and by children up to the age of 5 as well. And I think we need to, I'm not sure, Lisa or Sean, whether there's been any recent work around Healthy Start. I know that Kerry has been working on that, hasn't she? But one of the key priorities around that, which does include vitamin D within it, is around maximising the uptake of those vitamins, but then also associated with that are the vouchers that can be used for fruit and vegetables as well. So the combination of that Healthy Start work is absolutely key. As far as the link for vitamin D, this is also part of a work stream from the regional team as well. So I will raise that question with the regional team as to whether there's been any research done into the links between vitamin D and infant mortality. I'll have a look into that.
Thank you, Robin. So next I have Sue-Ann.
Thank you, Chair. And I suppose with my Safeguarding Partnership hat on, want to mention, Sean, the work which you probably are aware of around the Keeping Babies Safe work by Winnie Murray on behalf of the Safeguarding Partnership that commenced obviously after the increase in baby deaths and infant mortality during COVID. So there's a good level of multi-agency there's tools, understanding, which I think we need to, if not already, roll out around awareness raising, because it should be common language, certainly around children's practitioners across the sector. And I just want to come back on the Healthy Start for Life and whether or not we have properly aligned up the family hubs element for any of that delivery. I believe that we should be making sure that we've got that as a conduit for any kind of health elements as well. So I know you've got early help on your group, whether or not that includes family hubs. Yeah. Thank you, Chair.
It does, yes, thank you. So they were there and they started already sharing the great work that they're doing. Thank you.
Thank you. So, Alan.
Thank you, Chair. I suppose just to come in on Cathy's point there about other partnership working, I'm here today as well as a consultant in public health in my role as the co-chair of the Derby Place-Based Partnership Board, and I've just joined in the Health and Wellbeing Board in that role. Sean mentioned that as one of the key groups that are vehicles of the partnership boards, and I think that kind of mirrors the Health and Wellbeing Board from an ICB perspective, so I think that's a really good place to get that initial partnership working. But as you said, Cathy, it's really good to link in now with the Health and Wellbeing Board to get that wider determinant focus into that, because I think the Place Partnership Board has more of a delivery function with that, and I think that's been the key vehicle. So I, for one, from Sean's work and linking in through the chair of the Place Partnership Board, I'm really keen to get that join up between the Health and Wellbeing Board and the partnerships around here and the influence that these partners have.
Thank you, Alan. That's really helpful. Thank you. And we're glad to have you here. Thank you.
Thank you very much.
We are every partner in the room, but thank you for joining us. Do we have anybody else wants to speak right now? We'll be moving on. Paul will be mindful that this is a report next, and we did start late, Paul. I guess, do you want to come back, Sean, at this point?
I don't think so. Just thank you everyone for comments, and I've jotted them down. Thank you.
So thank you for raising awareness, or heightening our awareness anyway, of this very, very important issue. I mean, we are higher. Thankfully, statistically, the numbers are still quite low, though each one is a tragedy. So I suppose there's this issue, isn't there, about how do you target women who are likely to become pregnant, which obviously I don't need to describe to the room how that occurs or in what scenarios that can occur, which may not be, as you say. I mean, it's just something that does occur in sometimes for some people. So I suppose there's this issue, isn't there? So it easily feeds in straight away into all the integrated care strategy messages and priorities around obesity, non-smoking, but then there is that same, and this is persistent throughout the integrated care system as well, about focus on deprivation. And it seems to me almost when you've got such small numbers, you can do a really, really close analysis of who've actually died. Of course, there may be many more who might have been at risk of dying. You can do a really deep analysis of each case, can't you? And if you've got the data, you can look at that. So I imagine, I don't know if that's what you intend to do, or whether some of this comes with it, because we know that we know what the problems are about the rider determinants and the deprivation. It's just the specificities, and so, and then the issue is how do you then focus on those people who most need the advice? And with growing numbers, we've now got well over a third of year 11s who are obese. So I think there is a harsh, but hopefully put in a helpful way, health messaging to get out there that if you are obese, then that has all sorts of health consequences for you, including this. And I don't think those messages are out there, but they are. But that is a difficult message to put across. So it has to, it has to be done sensitively. So I think this is enormous. That's what I'm saying. It's enormous, and we need to take more from this. I don't know if Sharon, whether you need to help Sean and the public health, whether you can help the Sean and the public health team whether they need your help more in relation to engaging with schools. Because one of the problems we've got at the council now is that we don't have, you know, with so many academies, we can't influence schools, I believe, in the way that we perhaps could at one time. Or maybe that's a myth, Sharon. You could tell me that's a myth. That's my constant running assumption. But as I'm saying it now, maybe there's this myth or something when we had more influence in what happened in schools. But there's no direct, it's difficult sometimes, a direct influence, isn't there? But
Thank you, Chair. We're in a really lucky position in Derby. We have a really good collaborative school and early years system. So we have an inclusion strategy group that public health is actually engaged on. Remember, there's a particular great piece of work going on there around vaping in schools, for example, and the work that the public health team has been done undertaken in driving that. But the same is so for the work that we're doing around school nurses, health visitors. So across the system, there's a really good engagement. We have a secondary strategy group and a primary strategy group. So through those three, and a special schools and AP strategy group, and through those 4 different avenues, we're able to engage with all of the schools. 104 of the schools are signed up to out of 107 are signed up to an inclusion charter. So actually, I think the work that's been going on across the city with schools and with partners across the board, certainly since before the pandemic and intensified through the pandemic, has led to a really good system where we can tap in and have those conversations.
thank you, Sharon. I shall remember that. Next time I want something to spread into Sky, you may have opened something up there, so I should personally be remembering that. But that's really helpful, thank you. I need to close this, Councillor Hazelgrave, so is it very quick?
It is really quick, Chair. I think it would be worth us having a report back or an update a year from now on this. And I think also it would be worth trying to tease out, since family hubs came into existence on a stronger and wider footprint and level of input with wraparound services, whether that has had or tended to have a better outcome for children who would be expected to survive because the perinatal conditions didn't actually strongly lead to the possibility of dying. So some children could survive but didn't. Okay. Did the influence of family hubs and all that wraparound initial care and continuing care help to actually drive it down? Because that makes it a really strong message.
Okay, thank you. We'll take that. I'm sure Sean will take that on board. Thank you, Councillor Hazelgrave. So can I assume that the room is happy to accept the recommendations of this report, and also we have considered them. We've had some consideration of how they can influence the risk factors, and we've also talked a little bit, well, there is the issue of messaging. Oh, they've gone, it's disappeared. So there's the issue of messaging about safety factors. So I hope partners can think more on this, and we look forward to an update on this report. And thank you very much for the work that you've done on this, Sean. Thank you. So we are running a little bit late, but we did start late. So this sort of ties in and underlines much of what we've already discussed. So Paul Brookhouse from Derby Food for Thought is going to give us a report. I asked you, Paul, to report on the Child Poverty Summit. Thank you.
Great, thanks, Chair. I think the thing that I wanted to kind of start off, both Sharon and Sue-Ann said something I think really important, that when you look across all the things we're talking about, you know, child poverty is an underlying crucial factor within all these things, and I think it's really important that we recognise the starting points, and that's why it's important. You know, a lot of the work that's going on around child poverty and the reality of where we are as a city. For those who don't know, we did a Child Poverty Summit back in was it April or May of 24? Nearly said the wrong year. 24, where we highlighted, because of the work and the recognition of the city, we did something, kind of really looking at what short-term work we could look at as a city and how we could, recognise some of that. The follow-up event in November was crucially around the development of the anti-poverty strategy. that Heather's team has been working really hard on. You know, Shelley has really done a lot of work within that, and Jenny was following up in terms of that, in terms of, you know, really trying to make sure some of that. And what we used this follow-up for was to look at 5 areas really, in terms of to get people's views who are, you know, practitioners and people working in a whole stream around 5 areas. And I'll quickly, because I'll forget what those 5 areas are, and I'll miss one out. Health, housing, education, child welfare. And when we talk about child welfare, we're not talking about safeguarding in terms of what Suran's talking about. We're talking about the basic welfares of food, clothing, you know, all that side of it when we talk about child welfare, to clarify, and play. Because we recognise the significance and the drastic fall that there's been in terms of funding within nationally in terms of, you know, kids play. And so we ran the summit. Sadly, it was on the day after we'd pelted down with snow in November, so we probably had about 40 people that couldn't come because they're all stuck in their houses kind of outside of the city. But we still, you know, had a really great kind of number in terms of there, looking at those 5 areas, and we've had the feedback that has come back and different people's points and opinions, and we are just working on it in terms of how we share that information, because we don't want to just send it out in the format we have now, because it'll not necessarily mean so. So we're still working, trying to collate some of that as we're rapidly trying to make sure we get a final draft of the anti-poverty strategy. And so I think it's, you know, it's a crucial area that anyone that knows me won't be shocked that I will be provocative, you know, in terms of it. And I think child poverty is one of those issues as a city that we need to be provocative about, because it is a crucial issue that fundamentally affects the statistics we're hearing. You know, sadly, it's not a surprise when you look at child poverty, all the different areas we've covered, the issues we're seeing, those increases. And I think it was a, you know, very kind of, you know, productive event within the work that was there. And I'll look at Heather here in terms of, we are getting very close to having a kind of final draft of the anti-poverty strategy, you know, kind of, you know, they're ready within that, and Heather will kind of answer that one in a moment. But I think the important thing also to throw in there, that we are obviously in transition nationally within, you know, obviously government-wise, and within transition, you know, things sometimes can be, you know, appear to be painful, you know, because as you're trying to find long-term solutions, short-term, and I think it's really important that we do recognise as a city, you know, the short-term impacts that we are seeing across all areas around child poverty through nobody's fault, you know, in terms of, you know, within the city, it's a reality of where we're at within that. And when I threw out my comment earlier about, you know, a whole ownership as a city, you know, I think I've said, you know, regularly a few times that we almost need a COVID-style response to child poverty, where collectively all sectors come together. And I think this is me personally, you know, will say that I think, you know, the business sector can get more involved, and that's not because they don't want to. I think it's because they're not fully aware of the issues we are facing. If we shared all of the different things we talked about today, I think it would shock most of the business sector. And as a person of faith, I will say that the faith sector is probably not as involved as it should be on this agenda, and needs to be way more involved around issues around, you know, child poverty. And that's where collectively, you know, when I talk about ownership, there's got to be that kind of ownership, because we see that whenever anyone hears the stark reality we are in, people respond. I think you've got to be probably someone without a heart not to respond to anything around, you know, around the child poverty side of it. So I'm not going to go through the slide. I'm not going to go through all the stuff, you know, within the presentation, because I think it's kind of clear there. I think what I wanted to throw out, you know, we talked about obviously the recommendations, consider the report, but also allowing people to comment. But I wanted to go back to one of the recommendations that we talked about last time we brought to the table as well, which was about, as a city and within the health and wellbeing strategies, one of those areas, we need to make sure that child poverty is in all strategies of the city, because currently it isn't. And we need to make sure that anyone who's representing any of the boards, because of all the hard work that is going on, you know, with Heather's team and everybody else that's part of that, we need to make sure it's recognised within all strategies across the city to make sure that we really tackle this issue together and respond to that. And so I'll go back to Heather just in terms of about when the strategy hopefully will be at that point.
Yeah, just to say thank you. We did receive some feedback from members of Health and Wellbeing Board actually since our last visit.
Could you turn your mic off? Sorry, Paul.
Sorry. No, it's just to say thank you to members of this board, because we did receive some feedback on the item that we brought in November, and I know discussions did take place just in terms of how we could capture both existing activity but also, you know, potentially gaps in activity that need to feature in the poverty strategy. So we kind of have a finalish draft that certainly has been discussed with our Poverty Action Group, which is a partnership group, you know, of colleagues from across the city who are trying to obviously, you know, drive this forward. I think we do recognise that we probably need a bit more engagement. I think you know, it's just trying to make sure that actually, I guess, what is proposed in the strategy is actually going to, you know, is actually going to land. Is it going to make the difference at a community and an individual level? So I think we recognise that we probably need to do a bit more engagement. We are also, I mean, this is the council in particular. We are also just currently doing some training sessions around how we implement the socio-economic duty, and I think that is also, you know, I think bringing some reflections.
Sorry, Heather, training sessions about what, sorry?
On the socio-economic duty, which is obviously really relevant, and that is another way in which we can make sure that poverty, child poverty in its broadest sense, is actually reflected in decision making of the council. So that is something that we're looking at more broadly. But you know, wrapping that all up, we are hoping to have the kind of the, you know, the finalised version of the poverty strategy within the next couple of months. I think it's worth saying that we know that the government is also continuing to work on the child poverty task force, and obviously I think we always said that we would review the strategy in light of whatever comes out nationally. So it's just trying to kind of seize the opportunities that come our way, really. But ultimately, we very much welcome the support of this board, because clearly health and well-being, you know, it's integral to obviously the approach that we take around child poverty. So we will keep this board updated. Thank you.
And just one thing, can I add
you,
to that,
Heather.
if that's okay? It's just to say, I think the other thing for people to be aware of, I know Sue Ann's team and Sharon's team, we are looking as a city around the whole agenda of being a child-friendly city, looking at the model within Leeds, and it plays an important role within this in terms of tackling, you know, child poverty, and it's something that, you know, I think, I'm sure, you know, Sue Ann and Sharon will agree that to get the whole city behind looking at this and how that works and how it's relevant for us as a city is crucial for us as a city generally, but also tackling child poverty. And I think it's, you know, it's something important for everyone to be aware of.
So thank you, Paul. Thank you, Heather, and thank you for giving us that update. I mean, it's been a real theme of the meeting this far anyway, hasn't it? But I think that given that you organised that follow-up in November, I thought it was important that we bring it back here, that we don't lose, we're not losing into, this is not going to go off the agenda here. It won't go off the agenda. And, you know, there are limited things. With some things we can do, other things we can't do. Before I just bring Councillor Sesegrave in, I would say that I think that in relation to also what you were saying, Heather, and thank you for the work that you're doing, is that, so for, in terms of like awareness and sort of focusing on this and thinking about child poverty, I mean, for example, I know the Partnership Board is health inequalities is one of its focus, or foci, or focuses. But I think it, you know, and I'm thinking about, I was asking the room really, and is about, is that enough? You know, is that, I mean, I don't mean is it enough? I mean, clearly, you know, for everyone in the room will know that health inequalities, a big part of that would be, say, child poverty, particularly developing health inequalities over time. But if you say health inequalities, or you say socio-economic duty, are we really, is that enough of a trigger to think about children? I mean, I'm asking the question, I'm not saying it isn't. I mean, I know it would seem obvious to everybody, and perhaps many people in this room, but I'm not sure, you know, whether you need something that was more specifically articulating, you know, children all the time, rather than these more generic points. But that's a question I'm asking. I'll let Paul come in now.
Just on what Paul was saying about Derby becoming a child-friendly city. When I first took over the portfolio of children, young people and skills back in July, when I first met the senior leaders in the whole team connected with that portfolio, I did say I would like to see us moving towards being overtly and known as a child-friendly city, child and young people-friendly city, actually. And I think one of the ways we're going to be looking at that, because I think it's a clear sector of the population that we need to pay particular focus on, and particularly because of the deprivation. And also, just to point out that many of the children who are living in a deprived household, both their parents are working. That's the most alarming thing, really. And that's a clear point that everybody needs to understand as part of this awareness and being awake to it. So the way that we're going forward on this, I hope and will be driving for, is that when we refresh the Derby City Plan, we have that as one of the strands that goes across, not necessarily down, because inclusion will be going down, but a strand going across all directorates will be to make sure that we are awake to issues about young people and children from all sorts of aspects: well-being, health and well-being, the effects of deprivation in a household, limited opportunities for education and study in libraries and all that kind of thing. And the whole kind of youth picture in the round, that we address that through strands going across as well as some pillars going down, and that we really get a handle on this. And I will be visiting Leeds at some point, which historically has been a child-friendly city. I'm from Leeds myself, I'm proud to say.
Well, I think there might be a kind of mention now, actually. I thought there was
you
a
might
bit
have
of a
guessed
plug.
from my
There was a
accent.
Leeds plug,
Yeah.
but we understand it's for purely professional reasons that you're going to Leeds. So
Yes,
thank you,
absolutely.
Paul.
Yeah, and
Thank you.
in furtherance of this whole mission of, well, partly, but for other issues as well, to get a handle on that. I'm sure the history of being a child-friendly city has taken a bit of a knock for Leeds, like every authority, because of reduced resources, and of course that must be a factor in how we go forward. We don't have pots of money that we can suddenly release for this, but I think it's about coherence and coordination among all sorts of partners, including of course our voluntary sector partners, who we greatly value, to actually get to a point where we are more child-friendly, and it's quite clear, and youth voice tells us that they can perceive that as a change.
Thank you, Councillor Hesselgrave. So I've got Heather just wants to come back in, and then Amjad. Thank you.
I think Kim's before me, sorry.
Thank you. I think, Chair, you raised a very pertinent point. I mean, poverty and tackling inequality is high on the City Partnership Board agenda. There was a session held in November where we looked at the threats and opportunities across a range of different sectors, and poverty and inequality, unsurprisingly, is one of those. And will feature in terms of, our kind of topic reviews that we're going to do. The other thing that, because there is actually a meeting taking place tomorrow, is we are looking at the kind of the city plan in light of the refresh of the council plan. So certainly Councillor Hesselgrave's point around child-friendly city, and also the points that Paul Brookhouse has made, we will feed those in tomorrow. So thank you very much for the feedback.
Okay, well, we look forward to perhaps hearing a bit more about that then. Thanks, Heather, when we discuss child poverty next time, or quite soon again. Thank you. Amjad.
Sorry, Chair, I think it was Kim first and then...
Yeah. Oh, sorry, Kim, I didn't see you.
It's all right, don't worry. I think absolutely child poverty needs to be embedded, but it is that broader discussion, and to some point, Heather's just made my point. But actually what I would also say, it's about how we embed that within our day-to-day work. Things like commissioning, procurement, it's about health and wealth. If you are wealthier, you are going to be healthier. So actually what we have to do is look at the way we maximise incomes in the city, work to create opportunities. So to some degree, for me, the child poverty impacts on that. But there is an important discussion to be had at a partnership level and at a system level in terms of making sure that the policies and the procedures, commissioning, procurement, and the work that we do actually, as much as possible, encourages local wealth people to apply and supports that approach. And if we don't do that, we'll have missed a real opportunity to have a tangible impact. I know this is a national thing, inequality, prevention. There isn't much money in the system. It's about how we maximise that and how we work together to do it. So,
Thank you, Kim. Thank you. And Jed.
Yeah, thank you, Chair. Mine's just a quick point, and I think it's for us, it's reassuring to hear that recognising that engagement with communities when we're devising strategies, policies, because during the pandemic, coming out of that, very much communities were at the heart of it. As a sector, we feel that probably going slightly back towards old ways of working. So we need to be working differently. We've got to be putting communities at the heart. If we look at what we've discussed today, deprived communities, and within them deprived communities, ethnic groups, that evidence shows there's a lack of trust. And this is again where the sector comes in, and we've got to be working with that. Because if we look at from a child poverty perspective, locality 3 is there, or Breton Ward, the highest level. Again, it's our mostly densely populated with ethnic groups within that. So we need to be working differently, and we've got to be putting the communities at the heart of it, keeping them involved.
Thank you, Amjad. Thank you. Paul, did you want... So I just remind... You want to come back in? Yeah, just to remind the group then, the room, before we do that, the two recommendations are to consider the report here. Well, we've done that. And then to make a further recommendation, we've made comments, which is good. And I'm obviously, I'm sensing from the room that there's a lot of support and about the importance of the work around this, and to make any recommendations as well. So, Paul.
Yep, just one other thing to add is the Poverty Commission's next round of the Poverty Truth Network, which we haven't got time to explain to everybody now what that is, but it's about engaging with communities and people that have kind of lived experience but coming through and can advocate. The next round of that, we are specifically looking at around the whole area around child poverty and how we best, get some of that voices and people within within the whole area with lived experience, again, to make sure that we, as Heather said, we're going to have the strategy, but it's important to get that lived experience, kind of viewpoint as part of that. So we are going to be looking at as part of the Poverty Commission. So I just wanted to kind of highlight that as well for people.
Thank you, Paul. Right, I'm aware that we are running a lot over time. Are there any other comments on this? I'm sure we are going to come back to this. I personally think it's worth thinking about, using the word children in, just saying, are there any socioeconomic considerations, including as relates to children? This is what I'm going to start thinking about in the things I chair or I write, so that you've got a conscious reference to children there. It's not that we ever forget, I don't ever forget children, but I've got children, but I mean, I think it's a prompt. I think it might be quite useful actually, and I will be personally thinking about that further, but thank you everyone. If there are no more comments on this, we will continue with this work, and thank you for all the work that you've been doing, Paul and Heather, on this. Thank you. Right, we need to move rapidly on now because we are a little over time, and I'm really pleased that we've got the Health Watch report now. I think this was going to come last time, was it? And we had to, couldn't be delivered last time, I don't know. But we have Nav Sahota to talk to us from Health Watch about the NHS app, which I thought was a really interesting, just totally related to all the content in this report.
Thank you, Chair. I can't comment on whether this was going to come last time because I'm newly appointed as the Chair of Health Watch Derby, so it's my first meeting. This report was commissioned on the back of the Health Watch GP survey that was done last year as well. Joined Up Care had highlighted that the NHS app was an important tool for empowering patients and helping them to manage their own health better. And this prompted the Health Watch team to look through the feedback that they'd been getting through outreach work. And we'd had very little to none, to no feedback on the NHS app when talking to people in Derby. And hence we looked at doing a specific piece of work around awareness and people's experiences of using the NHS app. There were it was a very short survey, just 3 questions. We had 103 responses. So the first question was around awareness of the NHS app. How many, had people heard of it? Did they know about it? 48% of the respondents had heard of it. However, there was a notable sort of distinction in terms of ethnic background of people that were aware of the app. So just check, because they did combine some of the sections. So when looking at white, British, English, Northern Irish, Scottish, Welsh people, the awareness rose to 73%, so 73% had heard of the NHS app. When looking at Asian, Pakistani, Indian, Black and Caribbean ethnic backgrounds combined, this was only 14%, so 1/4. So a really big difference there. The second question that was asked was of those that were aware of the app, how many had actually downloaded it, so how many actually had the app. And the answer to that question was 59% had downloaded it. And the third question was of those that had downloaded it, what were their experiences of the app? So 41% had said that they had mixed experiences of using it, so found some bits of it useful, some not so. 35% had good experiences and found it useful, and 24% thought it was difficult to navigate and therefore not so useful. So they were the three questions that we asked, and then obviously we also had the demographic information that we were capturing as well. So from the feedback that we got, we also had space for people to obviously just leave any other comments that they wanted to leave on, how they found using the app. Health Watch Derby had 3 key recommendations. So the first was around inclusive awareness campaigns, both locally and nationally. I think since obviously the use of the app during COVID, there hasn't been as much of a push, and there's not, I think awareness is starting to wane. The second recommendation is the improvements to the app to make it easier to use, and the third being around ensuring set standards are in place for NHS professionals to update the app. Thank you.
Well, thank you for that report, and welcome to the board. It's nice that you're here, and thank you. And it is an important report, I think, and it just really speaks to my own experience of this app, which I hadn't realised was on my phone until I saw this was on the agenda, and then I have looked at it, glanced, and I realised I don't even know how I got on my phone, but I think you had to download it, something to do with the COVID jabs. So it's been sitting on my phone and recognised by me, and then I looked at it, and then today I read in the report that you can order repeat prescriptions on it, which I didn't know. And I mean, I must admit, I don't spend ages looking at apps on my phone. So I suppose I'll bring in people to comment, but I suppose I got the sense from the report that it could just do with a lot more promotion and a lot more, I mean, literally telling people to use the app or how you can use the app to make it worthwhile. Is that, and so, but it could be an excellent tool, I'm sure. So I'm going to bring in the ICB now. Kathy McLean, please.
Thank you. What an interesting study to have done, actually. I think clearly the Secretary of State's concepts around the shift to digital includes not just the way we all do our business, but actually how do we link with people. So it's all very, very relevant. I think that some of the findings about the accessibility for different people is really important. We often talk about those who are sort of digitally excluded, but actually that's, from every conversation, and whenever I raise that, people remind me that's becoming an increasingly small number, actually. You often think it's very old people, but actually it's not necessarily. But some of the things you found that, I mean, I assume you're going to feed this back somehow so that people can hear what's happened through that, because I suspect that this relatively small sample would be replicated if you did it elsewhere. So I'm sure the feedback would be good. But the potential for this is absolutely enormous. The potential, just the prescription thing, I mean, I must admit I do use that. And it's really, it must take out work for primary care. It must help generally, and you're quite in control of it. But But I think what's on it and what's available to each individual is quite different depending on where you live. And so I think it's got enormous potential. So I completely agree. But I would just suggest feeding back and some of those things, particularly about language. I mean, I don't know what its facilities are. I read it in English. But, you know, what if it wasn't my language? What would I do? I don't know. So good piece of work, but it's got huge implications, I think.
Thank you, Kathy, and I agree with that. Thank you. Margaret.
Thank you. So just building on what Kathy said, I totally agree with the recommendation of publicising this much more widely, and particularly the benefits to individuals of having it. Because not only can you get your prescription, you can book your flu jab, your COVID jab, you can read your medical records. There's an awful lot. In fact, you tend to see reports from a hospital quicker on the app than you see them from the GP, ironically. So realising those benefits are available, but how do you know if nobody tells you? And I've seen some campaign from the ICB, in fact, on Facebook promoting the app, and that's been quite useful. I've always shared that when I've seen it. But much more active promotion, I think, would be very, very useful. And I think in primary care or any encounter with an NHS professional, the app could be promoted, because almost certainly there'll be some sort of follow-up use for having the app after you've had that interaction, whether it's just the record that you've been, or it's the results of a test, or it's getting your prescription, or it's booking an injection. I think there is an issue with, if I think about my mum and her friends, I think they need help, actually, and maybe an audible form of it where you can use voice connection rather than have to type online might be useful as you go forward, because some of them are quite, they're not very, savvy on a phone particularly. But I think this is a fantastic tool and just should be promoted very widely.
Thank you, Margaret. Before I bring in Amjad, I mean, can anybody in the room comment on how it is promoted? I mean, I'm just thinking anecdotally, as someone who has to use Facebook a lot as a counsellor, and I see a lot, I see a lot of health messages, many of whom our own, Robin, I'm always sharing. But I don't remember seeing anything about the NHS app. I don't remember, and actually, if it weren't for this Health Watch report, I don't think I'd have looked at it on my own phone, which just shows you how I use the phone. But I'd also, if you say an NHS app, that term itself, it's not critical. This is, just reflecting, and it may be personal, but everything in the report I recognise. I tend to think, well, it might be something like just a guidance thing. Like you can go online on the NHS website, which I do think is excellent. Get excellent guidance, and I really trust the NHS website. But just saying the NHS app, to me, it doesn't tell me what it is. It doesn't suggest. So, would you like to come in on that?
Sure. Hello, my name's Jim Austin. I am currently the Chief Executive at Derbyshire Community Health Services, but 4 months ago was responsible for digital within Derby and Derbyshire.
A confession.
So I do have some inside information on this. So just for context, 55% of adults, so aged 13 and over, are registered with the NHS app across Derby and Derbyshire, and there is data we can get it down to general practice level. You ask about promotion, so there are some general messages that go out, but broadly, if you are in regular contact with your GP, if you have a regular repeat prescription, if you go to one of our acute hospitals, the booking and adjustment of appointments, Margaret's mentioned the information you get from test results, that there is a message that comes through with that, through general practice and through our acute hospitals around, you can use the NHS app to do that. You'll also have heard quite a lot of information around, if you're unwell, get in touch with 111. That is also available through the NHS app, and through some of those messages, you'll see that approach as well, because you can go into the app and you can do some of the triage to know where's the right place to get your care. So it's a big messaging thing. There's a lot of data that we have. We can see who's using it. We can see how many people are downloading it a month. So actually there were 758,510 people, or logins by
Not
people
in Derby and Derbyshire.
within Derby and Derbyshire. That will be in multiple people
Really?
doing it multiple times.
Sorry, can you repeat that figure?
758,510 across Derby and Derbyshire logged into the NHS app across Derby and Derbyshire. Imagine there's a population of 950,000 adults over 13 across that area.
That's very significant.
Well, it's people doing it 2 or 3 times, so there'll be a small number of people doing it many times, and there'll be a few people doing it once. It's not 758,000 individuals doing it, no. So there's a lot of information out there, there's a lot of publicity around there, and those that are frequent users of health services are more likely to be pressed into that space, which is all about trying to help people to help themselves with this stuff. So I know when I've done a repeat prescription, it's a lot easier to do it through that than it is to do the old method.
Thank you, Jim. That's really helpful. And I think the comments really that have been made are more about like it's not so much questioning the value of it and everything. It's just that how it might be seen more like a thing you buy in a hook. You know, what's the hook here? Like you have in a song. You know, what's the hook? And I'm not convinced. It's clearly being very effective, but I don't think it has the hook yet.
I think you're right. So there's a mantra around something needs to be useful, usable, and used. It's clearly useful. I think there are some usability things, and there's a whole roadmap around developments around things like better use of languages. Actually, Margaret talked about a spoken version. That's not on the offering, but I can see where you can have trusted people being able to use it on your behalf. There's a whole lot of stuff around that. And then the used bit starts with the numbers, and particularly if we're not using it as well as we could, you come back to that usability piece.
Thank you. Amjad.
Yeah, I think mine was around that usability one, because if we look, and it was interesting, the stats even are on that in your survey around ethnic groups, in particular ethnic groups that live in deprived areas. We know there's low levels of digital literacy within them areas, and often what you find is those that have English as an additional language are not literate in English. Often they're not literate in their native tongue as well, a language. So it's important recognizing some of the complexities. And again, it goes back that co-production, co-design at a grassroots level with some of our communities that we're trying to work with.
Thank you. I'm really mindful that I've not been very disciplined with time today. I was clearly put out by the late start. So any excuse. So very quickly then, Carmel and was it Lucy? Councillor Heathergrave, do you mind if you don't come in on this one? Because we're just running out of time.
I do have a really good suggestion.
Well, if it's about a 3-sentence suggestion. Councillor Ashby.
Thank you. Thank you for the report. It would be really interesting to know whether there's been any wider work nationally done and how the Derby response compares to that. And also, I mean, I had been thinking likewise with the very poor information, knowledge and use of it in the ethnic communities, whether a lot of that was related to language and whether there are plans for the NHS app to be available in different languages. I would suggest that the most common promotion of the app was during COVID, and that's, I suspect, when a lot of us got it on our phones, whether we use it or not, and that it does need more promoting.
Thank you, Conor. So just before I let you come back, I'll just have three sentences then from Councillor Heathergrave. Thank you.
Yes, I build this as a really good suggestion. You might all shout me down, but I'm just suggesting that when all the issues have been ironed out of the app, that we get our comms department to work with Radio Derby and or NHS to have a campaign for a week.
Thank you, Councillor Heathergrave.
And thinking of how we access and be inclusive in that campaign.
Thank you. Who is responsible for, Jim, this is surely one for you, if I may, who is responsible for promoting the app?
So technically it's NHS England, it's a national app for England, although Wales and Scotland have similar elements to it, and actually the development path is determined at a national level, so we are consumers of it. We can pass stuff up to influence, but our influence is limited.
Thank you. So we probably don't have the right to go out there doing our own promotion campaign.
No, I think we can promote the NHS app very freely if we wish to. Okay,
right, thank you. So we have a recommendation there from Councillor Heathergrave. Did you want to come back first, Nav?
Thank you. Just really quickly to say, linking on to what you just said there around the awareness, so we do have control to be able to do whatever we deem fit. in Derby to support use of it. Yeah, what happens nationally in terms of improving it is a different matter, but I think working within Derby to make sure that it's as useful as possible within the control of the city is important as well, and then the communication. Thanks.
Thank you. So I assume that this report will be going, winding its way through some connective route to NHS England anyway, if not through Health Watch nationally.
I will check on that.
Thank you. Because in that, perhaps the feedback on language, accessibility, usability could be conveyed, please, Nav, to NHS England, who are responsible for this. And then is the room happy to accept Councillor Hazelgrave's suggestion that we collectively think about a moment to try to promote the NHS app a little in what ways we can? Chris?
Yeah, you know, there's a repeated theme of mine about duplication, just careful, before we set off action, just careful things. So I'll take the action, if that's all right, on behalf of the board, just to link into the lead members in the ICB, including communications. I think that's the right thing, to just connect with our Health Watch colleagues, get everything that we can from this report, link it to ours, and then work with that, if that's okay. I'll take that action. Thank you.
Thank you, Chris.
You're welcome.
So the answer is yes then. Thank you. Thank you. Obviously, you know, as I've just said, it has to be contextualised within the owners of the action, doesn't it? But I think you know, just raising awareness of it locally in ways that we can would be helpful, because I just don't think there is. The figures you've given us, Jim, I think there could be more aware, and even for people who are already using it, some people like myself would need to be prompted, because I don't sit for hours playing on apps on my phone. I need to be prompted, somebody, you know, to tell me what it does. Well, as the report does, I need that prompt. So if that needs to be fed back, I think. So thank you for taking that on, Chris, and we need to feed that back to NHS England. And thank you ever so much for the report. Thank you. So now we need to move on rapidly to Robin talking to us about the delivery of NHS screening programmes in Derby.
Thank you. So there was a request from the board at the last meeting for some more specific information relating to the screening and the immunisation programmes. And we've got a summary today for screening, and then we're hoping to bring the immunisation summary next time. So just to the next slide. Thanks, Lynn. So you've got the report that was included in the pack. This was a report that was provided by our colleagues at NHS England, and just to say that their apologies today that they weren't able to attend, and so they asked me to share the information with you. So particularly and specifically to update you on the current national screening programmes, the arrangements around commissioning and provision, the performance and some of the quality improvement work. And you'll see within the paper there's quite a lot of detail around the specific work around health inequalities and the partnership work that we're doing together. So the next slide, thanks, Linz. So just to say at the beginning, at the start off, NHS England is accountable for delivering its responsibilities under this agreement, which is the Section 7A agreement, and it is NHS England that holds the accountability for the national screening programmes. And these national screening programmes are those that are approved by the National Screening Committee and sit within that Section 7A of the health services. There's a process in place to delegate this responsibility of the commissioning of the majority of the screening services. It's all of the programmes. There's just a few of the lab facilities or the central administration processes that will be kept by NHS England. The rest is being transferred to the ICB, and Chris Weiner has joined us as the responsibility will be coming through to his part of the ICB from April of 2026. And so there is ongoing work to look at this transfer to ensure that it happens safely and that all of the improvement work can continue. So what we've got in the paper is just a run through of each of the different screening programmes. And what I've done on the slides is not put the detail, but I've just pulled out some of the charts for performance. I'm aware that some of the numbers are quite small, but the majority of the information you have in the paper. So if you just want to move on, thank you. So the first programme that we have is the breast cancer screening programme, and that's for all women between the age of 50 and 70. And then after the age of 70, women can self-refer and continue to be screened every 3 years. I'm not sure of the awareness of that, but it is available to women as they come to the end of the programme. And there's also a high-risk annual screening programme as well for women who are identified to be at high risk, usually because of family history. And you'll see our programme is actually delivered by UHDB, and is a programme that covers an area much broader than the city, so Derbyshire and then into East Staffordshire. And the programme works closely with NHS England around the development of their Health Inequalities Action Plan. And we also work closely, we have a subgroup of the Cancer Board where many representatives from the screening programmes attend, and the UHDB breast screening programme are really active members and participate in that conversation and the learning that we share through that programme as well. So they are particularly at the minute working with 3 of the practices with the lowest uptake to understand what they can do to improve that uptake. And there's also planned to be a national campaign to improve uptake between mid-February and the end of March, which we usually as partners try also to promote. You'll see from the chart that we've got the dotted line, which is the England performance, and then we've got the blue line, which is the Derby performance. And you'll see that, you know, sort of 10, 12 years ago, we were doing pretty well in Derby, above that England performance, and we've stayed pretty much above that performance. The issue that we have is that nationally and locally we had a drop around the pandemic. There were some really practical issues around delivering breast screening. For anybody that's ever been into a mobile breast screening unit, it's very, very difficult to manage the movement of people in a COVID-secure manner. So there were greater spaces and lengths of time between the screening appointments and a lower capacity generally across the system. When we saw the screening performance dip, it is improving, but we've not yet returned there to the performance before the pandemic, and hence that continued work, particularly for some populations who are less likely to attend for screening. So that's the breast programme. Do you want to just go through to the next? Thank you. So we have the cervical programme, and this is generally delivered by general practice, but is also delivered through some of the sexual health services. And we divide the programme into 2, into the 25 to 49, where women are screened every 3 years, and then the 50 to 64, where women are screened every 5 years, and that relates to the risk of women of those ages. There's a link, of course, to this programme to the HPV virus and to the HPV vaccine programme, which is delivered through schools in year 8 and year 9. And that vaccination programme was initially just for girls and now is for girls and boys as well. We have done some really specific work in the city with a company called Kaha, who worked with a couple of our practices with low uptake to consider how some simple changes in giving a personal invitation to women using text messaging, emphasising the fact that it would be a female nurse conducting the test, and offering self-booking facilities as well to ease that booking. Some really simple practices that were done that really improved the uptake, and we're working to share that improvement across the practices in the city to consider how that can be spread. If we just move on to the next slide. So we'll see the direction of travel for the uptake of both of these screening programmes is the same. There's a decline generally in the uptake of cervical screening over the years, over both age groups, but you'll see that actually in those younger age groups, we've had a greater decline. There is a belief that perhaps in younger age groups who have received that HPV vaccine, there may be some misinformation or misunderstanding that cervical screening is less important. That may be one of the factors in this, but clearly there's many factors impacting across all of those age groups in that uptake. So some significant pieces of work to look at how we can improve the uptake of that programme. Then on to the next slide. So the BOW programme is initially for everyone aged 54 to 75, but is currently undergoing an extension to all over 50s, and that's every 2 years. You receive a testing kit through the post. Up until around 2018, up until around that change in the trajectory of the graph, the sampling was a 3-sample test. So people who were sent the kit had to test on 3 different days, 3 different occasions, and keep that sample at home with them. Since that change, it's actually been changed to a single sample, which we can see both locally and nationally. We can see a real improvement in the uptake of the screening programme, which we believe may be associated with that. There may be other factors, but we do think that has made the acceptability of the test much more improved. So our local hospital, UHDB, do run the programme, again, over a greater area than just the city. And they are, generally speaking, early adopters of any of the advances. So they were early in adopting the extension to the over 50s. And they're also looking at, as is mentioned in the paper, a decrease in the threshold of that screening test at which they'll invite people for further testing. And the aim of that is to see if that will improve the detection of bowel cancer. We've also undertaken across Derby City and the county a health equity audit, which we're just waiting for the report to come from. Unfortunately, the national screening programme do not record ethnicity within their data set, and so we are required to use some other matching. We're actually using a system called ACORN, which matches the residency of individuals with particular characteristics that they have in order to understand a little bit more around the populations where there's low uptake. So we will hopefully within the next couple of months have the results from that and be able to target our work much more closely. Next slide. So the next one, they're the 3 cancer screening programmes. The next one we have a slide for is the AAA, so the aortic aneurysm screening programme. And this is a male screening programme. It's a single snapshot. It's looking for, we're using a scan to look for an aortic aneurysm, which is a widening and a weakness in the main vessel that can be seen through scanning the abdomen. And the purpose of this is that aortic aneurysm is a cause of very sudden death and really significant morbidity in those that it occurs with. And if it can be found, it can either be monitored or referral can be made for surgical repair. So it's a really key screening programme. It's a really key condition that's associated with health inequalities as well, because it relates to poor cardiovascular health. And some really good news around our local programme is that it performs very well compared to the national programme and has also recovered really well since the issues around managing the programme during COVID. So the next programme is the diabetic eye screening programme, and this is to prevent blindness effectively and sight loss within people with diabetes. It's provided to everyone over the age of 12 years who are on the diabetes register, and you'll see again that there's some really good performance of this programme locally. The key issue that we have is those people who persistently don't attend, as they are the most at risk of significant issues related to their diabetes. It's a really good way of picking up any early changes, and treatment can be provided in the early changes that can prevent further sight loss. So that key concern around the, as is described as the regular non-attenders for this group, and there has been some work to look at those, specifically making direct contact with individuals to understand why they're not attending and to see if any changes can be made to tailor those appointments and make it easier for people to attend. And then the final programme is the antenatal and newborn programme, and this is combination of 6 programmes, 3 that are conducted during pregnancy and 3 that are conducted after delivery. And you'll see the details of those in the paper. This is a really, really complex programme of work, but again, the good news is that for antenatal screening, some really, really high levels of achievement with the coverage of the programme. And this is particularly as it's delivered through those antenatal contacts with the midwife. So during antenatal care, this is a constant conversation. So the antenatal programmes look at both the potential for fetal anomaly, so using scans to look at the development of the baby, but also for infectious diseases, particularly HIV and hepatitis, and also for sickle cell, so looking to see whether the mother has any evidence of carrying sickle cell or thalassemia. And if that's detected, then the partner can also be tested to see if any further work needs to be done. When we look at the screening programmes after birth, there is the blood spot or the heel prick, as some people would remember it as, which is looking at, I think it's up to 10 now, conditions that can be found in the baby. And the importance of those is that if they're found in those first weeks of life, there's interventions that can be made to make a real difference to the health of the baby. The key issue in the paper that's referenced is around the avoidable repeats, and this is around the successful taking of the test. For anybody that remembers it being taken, if you've got your own child who's had this test, it's taken as a stab into the heel and then a dripping of the blood onto a piece of card. And there's some specific techniques around doing that to ensure that it's a sufficient sample. And obviously, if that sample isn't sufficient, there needs to be a repeat, which means the baby needs to be stabbed again, which is nice to avoid, but also there's a delay then in receiving those results. So that's a key area of the performance that they work to constantly improve. And then there's the newborn hearing programme, for which we have an excellent local service that has really, really good coverage, works really hard to ensure that parents have accessibility to that test, and also performs better than the national averages. And just to say, just a key point from the antenatal and newborn screening programme, one of the key factors in that antenatal screening programme is to ensure that women are booked early. And that's one of the key issues that around inequalities in antenatal care. It's really important that women are booked by 10 weeks of pregnancy, because that ensures that they can access all of that healthcare throughout their pregnancy. So that's, again, a key area of work for the LM&S as well. So that's a run-through of the screening programmes. Very happy to have any questions, and as I said, we'll be able to bring a run-through of the immunisation programmes next time.
Thank you, Robin. Before I bring Cathy in, I'm just mindful of time. So, Robin, I'm going to propose that we leave the items 10, 11 and 12 as just items for information. We don't speak to them. Is that acceptable to you, as you were going to present on all of them? So there are a few minutes then. I'm going to take questions for a few minutes, because obviously this is another very significant report. Cathy.
Thank you very much, and very helpful to see this all laid out for each of these screening programmes, and really pleased to see that some of them we are actually performing very well. But it strikes me that there's a bit of a theme that's been running through the meeting, actually, which is around the inequalities and how we support people who, you know, are not necessarily the ones rushing forward to have screening. And I'm sure everyone will be thinking about ways to do this, but I would just point to, for example, the targeted lung health checks programme, which I know we're going to be doing, or we are starting to do, but has been in place in Nottingham for some while now, and is supremely successful. And the key element there is taking the screening into the communities, and that seems to be a really important message. So I just mentioned that because it strikes me that we're not going to get some of these levels up unless we do something a bit different to make it accessible for everybody. But good to see, thank you.
Yeah, I think that's a really excellent point, actually, just from what I've heard in meetings and reports. I think that's a really important factor. Any other comments on this, Councillor Kerr?
Yeah, thank you. You mentioned that related to the diabetic site checks, there are regular non-attendees. I wondered whether the levels of, 70% or 60% or 80% for the cancer checks, for example, are also regular non-attendees, or whether some people skip it because they did it 2 years ago and want to do it in 2 years' time. Or whether they are also full of regular non-attendees. Do we have those stats? Because if that's the case, then I think the messaging that needs to go out is different to the messaging to say, yeah, you think every 2 years is too often, but please do come, is different to saying, please come because we've never seen you. So that's the first thing. The second thing was, why is it only men for the aortic, whatever it was, aneurysms? Because I've known two people, one who sadly died from this, who was a man, and the other who was continuing to be monitored, who was a woman. So I don't know why there's the gender difference. It may just be my random selection of two people. And the final thing was a reference from this to the next paper, which we're not going to take, on the cancer side of things, because the health promotion is so important. And if we get the health promotion and protection right, then we should have lower levels of cancer to find. And we should be getting lower levels of other things as well to look for. And I don't want us to forget that, because there are things like internal air quality or the use of pesticides in cities that we should be discussing, and it would be good to have them come here.
Thank you. Before I just bring Robin in, I mean, we do have air quality reports here. I think there's another one just been created, hasn't there? And that will probably come here. In fact, there is going to be a focus on air quality at, if not the next meeting, then the subsequent one, Lucy.
It's internal air quality. We do a lot about external air quality and pollution from traffic, for example, but we don't say much about the internal air quality, which can come from the use of air fresheners or off-gassing from plastics or whatever else it is that we don't talk about enough.
Okay, thank you, Lucy. Okay, Robin, do you want to respond?
Thank you. So I think I would say some of the programmes will be aware as to whether it's the same individual who has persistently not attended or whether it's different individuals. It depends how the data is collected, but I would say it will be a mix of both of those. There will be some people who have attended before who've not come back, but there will be some people who've never received any of those screening programmes. So the importance is that that there's a drill down towards understanding why those individuals are not attending, which is an example from the breast unit at Derby, who've been making individual phone calls to people who haven't attended to understand, is it about accessibility, is there something about the time or the date of the appointment, or is it an understanding about the test to see whether there's anything that they can do. So it is about that individual level intervention for some of it. Just on the AAA, that relates to the assessment and advice from the National Screening Committee. So they look at the evidence around risk for individuals. And we know that men are at much greater risk around cardiovascular disease and poor outcomes from that. So they assess the risk and then the potential harm of a screening programme, and we'll look to see who will get the greatest benefit. So that's why it's particularly designed for a particular cohort of people, and that is something that they do constantly continue to review. And just on the continued health promotion, I would absolutely agree. When we look at the causes of cancer, the causes of diabetes, the causes of cardiovascular disease, which all of these screening programmes relate to, actually there's a huge overlap between all of those issues. And if we're tackling some of those, we're actually tackling prevention for many of these conditions.
Thank you. Right, and there's also Kathy's point about how can we do more in the community, which is a bit of an ongoing consideration, I think, isn't it, Robin?
Yes, yeah. So, I mean, some of the programmes are delivered in the community, aren't they? And some of them are not. Yes, it is ongoing around that consideration about issues that people have with attending, but then also the promotion within the community as well. So there's some recent work done not related to the national programmes, but around prostate cancer that was recently done with support from Community Action, which was really, really successful in delivering something on a Saturday in a community venue, which had excellent uptake. So it does just show, I think often it's very easy to assume that people don't attend for screening because they don't want to, but actually there's multiple reasons behind it.
All right, thank you, Robin. I mean, there's so much more we could say on so much, but I think I apologise for going over time today. It's the first time we've gone significantly over time. That's just such compelling topics and perhaps slightly over full agenda, which Margaret and I did allow, didn't we? But we were just so tempted by all of it. It's difficult to discern which is the most significant because it's all significant, but we will perhaps have a slightly shorter agenda for next time. But thank you for all the engagement, thank you for the participation, thank you for coming, and I look forward to seeing you all next time. Thank you.
Thank you, Chair, as well.